from star until it comes.
Sometimes back is into now I received that. Shall I open my video?
Okay. Okay.
Sign up.
I have already signed up. You can just go to that. On channel as well.
Good morning, everyone. So, welcome to today's clinical meeting. We'll start with Medicine 4, presented by Dr. Sivaranjini. I request to all the speakers to limit your talk to just 10 minutes so that we can have time for discussion as well. Okay. Start.
Good morning, everyone. I am here to present on behalf of Medicine 4 regarding Mr. S, who is a 67-year-old farmer who came from Tirupattur, presenting complaints of 1 month of abdominal pain, which was limited to the epigastric region, pricking type of pain, and it was continuous, non-radiating, with no specific aggravating or relieving factors. He gives a history of 1 month of loss of weight, which was approximately about 10 kgs, but however, it was not documented. In the past 1 month, there was a continuous sense of nausea since 1 month. No history of fever, abdominal distension, cough, dysuria, obstipation, hematuria. There was gradual decrease in his appetite. In the past, he is not known with any comorbidities, no history of substance abuse, no history of complementary and alternative medicine use. At arrival, his vitals were BP of 130/70 with a pulse rate of 102 with a respiratory rate of 20. He was with a temperature of 99. And for further examination, he looked dehydrated. He was evidently pale with no evidence of icterus, cyanosis, clubbing, pedal edema, generalized lymphadenopathy, JVP not elevated. Examination of his cardiovascular system was normal with a normally heard first and second heart sound. Respiratory system examination was normal with normally heard vesicular bed sounds. And per abdomen, there is tenderness in epigastric region. However, there was no mass or any organ that was palpable. No signs of free fluid and bubble sounds are here normally. Examination of his CNS system revealed no focal neurological deficits. So from his history and examination, we arrived with a symptom complex of abdominal pain with loss of weight with pallor. I would like to ask for the differentials. Thank you for your the responses. So we initially thought of differentials considering neoplastic origin, probably to CA stomach, and infective origin of abdominal TB. However, there was no fever. Inflammatory, we thought of GI vasculitis. and we further evaluated. He was found to be anemic with an initial HB of 8.7. However, he has a normal total counts, and the platelets were around 1 lakh to 1 lakh 50,000. And since his initial ABG, we noticed two things. One is he is in a state of acidosis often, and there was accumulation of lactate. Then he has features of deranged renal parameters. An ultrasound abdomen was done initially to rule out any emergency causes that showed only enlarged appendix of 11 millimeter with periappendicular mesenteric inflammation and adjacent increased vascularity. We further evaluated with the CT thorax abdomen with a abdominal angiogram that showed mildly thickened appendix 14 millimeter with no periappendiceal inflammatory changes and no evidence of mesenteric ischemia. So at the end of this evaluation, we rechecked our differentials. Those no features of CA stomach or abdominal TB or GI vasculitis could be made out since his ANCA were all negative. So we further refined the syndrome complex of abdominal pain with loss of weight, with failure, with elevated lactates and with elevated LDH. So considering into the elevated lactates, we looked for the causes. The lactates can be always a measure of hypoxia, but however, the hypoxic causes like mesenteric ischemia or CO poisoning or shock were ruled out. We looked for the non-hypoxic causes, that is malignancy, drug-induced and or alcoholism. From the history, we were very confident that he is not a ethanol consumer and no suspicious drug intake was in him. So we thought of malignancy and we went with a bone marrow biopsy and he was planned for Scopis also. Meanwhile, his bone marrow revealed 50% blast. So during the course of the stay, he worsened and required ICU care and bicarbonate infusion in view of worsening respiratory status with acidosis. Since his bone marrow aspirate showed blast, he was planned for immunophenotyping for further characterization. And a possibility of lymphoma and leukemia was also explained to the relatives. However, after a family meeting, the relatives decided to discontinue treatment and take him home. So at this from the patient, I want to discuss about whether lactate is only a marker of hyperperfusion. And as already said, there are non-hypoxic causes of elevated lactates also should be considered. Like the common drug, we usually use metformin at its toxic dose or will cause lactic acidosis, and alcoholism causing thiamine deficiency, interrupting with the pathway of glucose metabolism will also cause lactate accumulation and malignancy. So I want to highlight about this, how malignancy is having the elevated lactate. In the normal cell, in the anaerobic environment, the glucose undergoes glycolysis and yields pyruvate, which on further metabolic process leads lactate and 2-ATP. However, in an aerobic environment, the normal cell prefers entering into the mitochondrial oxidative phosphorylation pathway that yields higher energy of 36 ATP. But considering the cancer cells, even in aerobic environment, the glucose after forming pyruvate doesn't enter the mitochondria. Rather, it prefers to form lactate and 2-ATP. And this effect is called the Warburg effect. And why is this and what is the added benefit? There are two reasons. The complete oxidative phosphorylation is time consuming. Cancer cells are characterized by rapid growth. Hence, they prefer Warburg's effect, which takes only a few seconds. And production of lactate is a survival mechanism of the cancer cells, thereby producing the acidic environment. This forms the basis of the acidic medium invasion theory. Acidic environment is toxic to the tissue macrophages that identify the cancer cells. Since formation of the lactate favors the local spread of the cancer cells. We looked into the literature. There are many cases, but this case is closely resembled to our case. This patient, 79-year-old gentleman, presented with acute abdomen and severe lactic acidosis, was evaluated initially as a surgical abdomen, underwent laparotomy, then at the late stage was found to have non-Hodgkin's lymphoma. So I would like to highlight the timely refining of our initial differentials and the Warburg effect and its clinical application as the take-home message. Thank you.
Thank you, Sivaranjini. Any comments or questions? So what is the cause of abdominal patient?
Sir, accumulation of lactate itself is a nociceptive.
And the peripheral smear did not show any blast.
Yes, sir. Peripheral smear no blast was seen.
What are the counts? Total counts?
It varies, sir. Initially, it was 12,000 with a predominant of neutrophils. Then within the range only, sir. No leukopenia also, no leukocytosis.
There are no other questions. We'll go on to the next talk by Dr. Sam, who's presenting on M5.